Hello and welcome to the Basics of Physiology, the part 7, chapter 2. In this we shall be discussing about the action potential and the synaptic transmission. We will be discussing how the action potential occurs in the neuron and other cell types. Discussing how the action potential occurs in the neuron and other cell types. Yeah. And then we also be discussing the synaptic transmission. Alright, my audio and video, if you have any issues, immediately please message me so that I can change. Hope the diagram is also visible to you, but nevertheless I'll draw again and show you what are the important points to be understood in this. All right, so here we will be discussing first the neuron action potential. The neuron action potential helps us to understand the voltage gated ion channels, which I discussed in my last class. It helps us in understanding what are the properties of this action potential. Why is this action potential essential for us for transmission of signals across the nerves or muscle types or different cell types? What is action potential? Action potential is defined as it is rapid depolarization followed by repolarization. Rapid depolarization followed by repolarization. I already told you in my last class that a muscle is polarized. A cell is polarized from inside. If you look at this diagram, you'll understand what is our action potential. All right. If you look at this diagram, you'll understand that there is what is called as resting membrane potential, which we already discussed in the last class. The resting membrane potential I discussed. Just 1 second. So if you remember, I'm really sorry for the few change in the settings. Yeah, I think I'm okay now. So if you understand the resting membrane potential in my last class, so the upper aspect of the diagram here represents the outer space. See, this is the outer space. Okay, the outer space. And here I can also show you the yellow color one is the cell. Inside the cell we have got a lot of potassium ions, and outside the cell we have got sodium ions. Say suppose I'm just giving you an example. Outside the cell we have got so many ions which are predominant in high concentration. Inside the cell we have potassium ion as a chief ion which is in high concentration. So high concentration of potassium inside the cell, outside the cell sodium. This is giving what? Inside is negative. So inside it is negative resting membrane potential, and outside the potential outside the cell is positive. This is resting membrane potential. So are you able to follow this? This is resting membrane potential. So I'll make it slightly, yeah. So here we have got positive charges. And inside we have got negative charges. Inside the cell we have got negative charges. All right. And then yes. So say suppose the voltage gated sodium channels open. So in the next figure number 2 here, figure number 2 here. So the voltage gated sodium channels are opening up and it is allowing the sodium to move inside the cell. What will happen if a positive charged ion moves inside the cell? The cell gains positive charge. Previously it was negative, now it has become positive. Previously it has got some polarization, now it is got depolarized. The voltage was destabilized here, so we are calling it as depolarization. So this property is called as depolarization, gain of charges inside the cell because of opening up of channels. It is called as depolarization. Once the whole of the inside the cell gets depolarized, that is becomes positive, what will happen is, once the whole of the cell gets positive, what will happen is at one point of time there is no more exchange of sodium inside. Sodium will not enter inside now because a lot of sodium has accumulated inside the cell like this. Now what should happen? Again, the aim of equilibrium potential, I told you in my last class, is to bring back the charges equal on both the sides. So what will happen now? Ungated potassium channels will open. This will help in movement of potassium outside the cell. Because of movement of potassium outside the cell, again the cell is losing the electrical charge, that cell is losing the positive charged ion outside, and this becomes a repolarized state. It becomes a repolarized state. So resting potential followed by depolarization followed by repolarization. Resting potential followed by depolarization followed by repolarization. All right, followed by repolarization. This is what is the important fact you need to understand. This is what is today's class discussion. All right, we'll discuss how this property occurs in a motor neuron, how is it occurring in the skeletal muscle, and how is it occurring in the cardiac muscle. We'll try to understand 3 cell types. So what is action potential? Action potential is defined as rapid depolarization followed by repolarization. Action potential is defined as return of the membrane potential back to resting potential. From resting potential, it has got depolarized, repolarized, and come back. That is called as action potential. Now, action potential of various cells we'll try to understand, but first we'll try to understand what are the properties of this action potential. So in this diagram, if you see, initially the resting membrane potential is minus 70. The resting membrane potential is minus 70 millivolts. All right, resting membrane potential is minus 70 millivolts. So if you observe this, what happens is opening up of sodium ligand gated calcium channels or sodium channels will open. All right, so ligand gated calcium channels or sodium channels open to depolarize the cell. So slowly the resting membrane potential is rising now. The resting membrane potential rises slowly from minus 70, it becomes minus 55, and it reaches a threshold. This is called as threshold. Threshold means minimum amount of potential that is required to begin the action potential. You are calling it as threshold. After this, what's happening is suddenly when the cell reaches the threshold, it helps in opening up of voltage gated sodium channels. This point you have to understand. Voltage gated. So initially what happened? Ligand gated channels have played an important role. Ligand gated channels have played an important role in bringing the from minus 70 to minus 55. Once the cell is in minus 55, suddenly the voltage gated sodium channels open, and that increases the positive charge inside the cell, causing increase in the potential. From minus 55 it becomes 0, it rises to become 0, then from 0 it goes up to plus 30. Now at one point of time, once all the charges have reached the maximum potential saturation, once the entire cell is getting saturated, after this what will happen? The sodium channels close. Once the sodium channel close and the potassium channels are always open because they are ungated. Last class I told you ungated potassium channels are open. So if they are open, easily potassium ion moves out. Hence, if potassium ion is moving out, then the potential falls down. Falling of this potential, you are calling it as repolarization. It falls down to below the minus 70. And when the cell returns to the resting membrane potential, the voltage gated sodium channel, the potassium channel also close. All right. So that the resting membrane potential is back to normal. So what is the purpose of this? What is the function of this action potential? In a nerve, the action potential serves the important function of conduction of neuronal signals. In a nerve, the action potential, in a neuron, the action potential is responsible for conduction of signals. Whereas in a muscle, the action potential is responsible for bringing about the muscle contraction. Hence the activity to initiate muscle contraction, So if you observe the three important cells, in a graph, which I'll show you like this, of potential difference on the y-axis, time on the x-axis. Time on the x-axis, we try to understand. So if you look at the muscle, if you look at the motor neuron first, so motor neuron action potential is depolarization followed by repolarization. Skeletal muscle action potential is depolarization followed by repolarization. The cardiac muscle action potential is depolarization followed by repolarization. So this is the cardiac muscle. This is the skeletal muscle. This is the skeletal muscle. And this is the neuron. What is the difference that you see here? The difference is based on the potential and also the time. So here it is close to 2 milliseconds. That is the 2 milliseconds wide. This is close to 5 milliseconds. Whereas the cardiac action potential is having 200 milliseconds. What does that mean? It means that it has got a very, very wide potential. This wide width of the potential, depolarization followed by a delayed repolarization. Depolarization followed by a delayed repolarization. We are calling it as, there is something called as refractory period, which helps in widening of this cardiac action potential. Why is this happening? It's happening because of the ion channels. Difference in the ion channels. I already told you what are the different types of ion channels, but still we'll discuss. Now we'll discuss in details. We'll discuss there are fast channels and slow channels. There are voltage gated channels, ungated channels, ligand gated channels. So here we'll talk about voltage gated sodium channels or fast channels. We have got fast sodium channels or voltage gated fast channels of sodium. Voltage gated sodium channels. Whenever the opening up of sodium channel occurs, whenever these channels open, opening up of these channels is responsible for rapid depolarization or upstroke. All right, opening up of these channels is responsible for rapid depolarization or upstroke. So I'll draw an example of this channel. This is the cell membrane, the bilayered lipid phospholipid membrane, and these are the channels. These are the channels. So if you talk about the entry and exit of the sodium, say suppose this is a channel. In a resting state, it is closed. It is closed, and outside we have got positive charge, inside the cell we have got negative charge. This you all know. So once it is open, because of voltage difference, when it opens, it helps in movement of sodium inside the cell. Hence we are calling it as a voltage gated fast, and this is occurring rapidly, so you are calling it a fast channel. The fast channel has 2 gates and 3 conformational states. So 3 conformational states and 2 gates. What does that mean? It has got a closed state at rest, it has got an open state and inactivated open state. So it has got 3 conformational state. One is closed state, another is open state. Open state is again activated open state and inactivated open state. So these are the conformational changes 1, 2 and 3. Conformational changes that are occurring in the structure of the molecular nature of the ion channel, so that the closed state, the activation gate is closed, and obviously because the actual activation gate is closed, the sodium conductance is slow. So sodium conductance is very slow, it does not occur or very slow. Open state, what will happen is depolarization. Because of depolarization it opens, and because of this the conductance increases. All right, and the intracellular sodium concentration further increases. Further depolarization opens up more channels, and this is occurring very fast manner. Hence we are calling it as fast channels. There are numerous sodium channels which are fast in every cell, and every second, every fraction of a second, these open and close, and hence we are calling it as rapid channels or fast channels. So please remember that sometimes in diseases like hyperkalemia, what will happen is it increases the depolarization. It causes depolarization of the fast channels, and because of this what will happen is hyperkalemia keeps the cell depolarized always. Because of hyperkalemia, the channels are open always. Because of this what will happen is the fast sodium channel is unable to come back to the resting state, and this reduces the number of fast channels in a cell. Hyperkalemia reduces the number of fast channels in the cell. Number of fast activated state, the fast channels are reduced, and because of this the neuronal excitability, what will happen to the neuronal excitability? Because of this the neuronal excitability comes down. Neuronal excitability gets drastically reduced as seen in hyperkalemia. You have to understand this part. So once the cell is open, depolarization has occurred, now the time has to come, it should be inactivated. So after opening a channel, what will happen is it gets inactivated. After opening a channel, the channel has to get inactivated. The fast sodium channel, typically what will happen is it transitions, it moves from activated state to inactivated state. This transition, this activated gate, once it is open, whenever the membrane potential becomes more positive, at one point of time the membrane potential reaches a saturation. Saturation means what? No more further exchange of ion is possible because of the change in the difference in the voltage potential. Once the cell undergoes depolarization, maximum limit of depolarization, after that repolarization starts. So once the cell repolarizes, what will happen to the fast channels? The fast channels are bring back to the closed state. So I can tell you, I can show you one flow chart here. First step is closed. From closed it becomes inactivated open. From inactivated open it becomes activated open. From activated open again it goes back to, from inactivated open it again goes back to the closed state. So depolarization followed by repolarization, and this is the process happening. Once the sodium channel inactivates, it cannot go back to the open state now. All right, did you understand this? An inactivated channel cannot go back to activated open. It has to go back to closed state, then again come back to the activated state. So this is the process, and this process is occurring so meticulously, every fraction of a second it is occurring. Please remember that extracellular calcium, it blocks fast sodium channels. You have to remember this point. It's a property of calcium. Extracellular calcium, it blocks fast sodium channels. I already told you that hyperkalemia also keeps the inactivated state, prolonged inactivation of the sodium channels, hence the fast channel activity is coming down. All right, neuronal excitability comes down. Another type of important channel that you need to understand is voltage gated potassium channel. This voltage gated potassium channel is actually closed in resting state. So at rest it is closed. But whenever depolarization occurs, depolarization opens the potassium channel. But what will happen is it is a slow channel and it opens at depolarization. These are the properties of voltage gated potassium channel. It opens at depolarization, and its primary mechanism is, once the depolarization is complete, its primary mechanism is it brings about repolarization. It is there to bring about repolarization. This point always you remember it. All right, next we'll try to understand what are the different action potentials. I already told you that to begin the action potential, some small amount of sub-threshold stimulus is required. Once it reaches the threshold, depolarization starts. Once depolarization becomes maximum, repolarization starts. So to understand these steps, we'll further try to understand what is a sub-threshold stimulus, what do you mean by sub-threshold stimulus, and how is it important clinically. We'll try to understand before understanding the properties of action potential. So what is a sub-threshold stimulus? Please remember that to begin, see, suppose you started studying today, you're not getting any mood to study, so you are at a resting membrane potential state of, say suppose you are resting membrane state of minus 70 millivolts. So if in my class is like a sub-threshold stimulus to it, in my class, whatever you are listening to it, slowly your voltage difference is rising and it has come to minus 55. So this minus 55 is called as threshold stimulus, and anything below this you are calling it as a sub-threshold stimulus. Sub-threshold. So the degree of depolarization that is required that to begin the action potential, but this will, the initiation of action potential is bringing the difference, the voltage difference, very slowly to the threshold level. You are calling it as a sub-threshold response. So before going to sub-threshold response, we have got multiple attempts of sub-threshold responses which never reach the threshold also, which get unnoticed. You cannot notice also. So before you stimulate a nerve, there are multiple small attempts of subthreshold level which do not reach the threshold. All right. So membrane is repolarized here, or resting state. If you summate these, these are added, what will happen is one particular stimulus slowly it helps in bringing the threshold level, the action potential to the threshold level. Thus the beginning of the action potential occurs. So this is what is a subthreshold stimulus. Once the threshold stimulus has reached, so initial stimulus, if it is not strong enough, the action potential will not reach the threshold. But if it is slightly strong enough, what will happen? The action potential gets initiated. The threshold stimulus of -55 in this diagram, the threshold stimulus is actually critical to open up the fast potassium channels. But who is opening this? Who is causing this? It is the ligand-gated sodium channels or ligand-gated calcium channels or sodium channels are causing this threshold subthreshold stimulus to reach the threshold. Once it has got reached the threshold, after this what will happen is the action potential gets initiated and you get an upstroke like this. To reach the peak. This peak is brought about by the fast moving sodium channel, the fast sodium channels, also called as voltage gated sodium channels, open. The membrane potential becomes positive. The fast sodium channels open and activated from the closed state. After that, what will happen is once the equilibrium potential is reached, so this is the top peak, we call it equilibrium potential. Equilibrium potential has reached. If the equilibrium potential has reached, now the sodium channels undergo inactivation. Once the sodium channel undergoes inactivation, there is repolarization to begin. Repolarization begins like this. So here we have got fast sodium channels in the inactivated state, but we have got voltage gated potassium channels which are open here. So next step is the voltage gated potassium channels are open here, and because of this what happens is the voltage gated potassium channel, in response to depolarization, they start, but they are very, very slow. They are not fast channels like sodium. They are slow channels. I told you 3 important properties, and their main aim is to bring about repolarization. So once they are open, the potassium moves out of the cell. The potassium conductance moving out of the cell results in fall in the equilibrium potential, fall in the membrane potential. The fast sodium channels are inactive. The slow potassium channels are open. The sodium entry does not occur, but potassium exit is continuing. Because of this, what will happen? And high conductance of potassium channel, they are slow channel. Because of this, what happens is the cell loses the potential. You call it repolarization phase. All right. Once the equilibrium potential becomes first 0, then negative, then it reaches even below the resting membrane potential. Then what will happen is again the next subthreshold stimulus starts to cause upstroke of the action potential. Please remember, the upstroke of the action potential is mediated by fast channels. The downstroke of the action potential is mediated by the slow channels. The upstroke is mediated by the fast sodium channels. The downstroke is mediated by the voltage gated slow potassium channels. Though they are slow, but the conductance is high. Though they are slow, conductance means movement of potassium ion. Conductance is very, very high. So the action potential is all or none phenomenon. That is, if the threshold is reached, nobody can stop the action potential. If threshold is not reached, action potential will never occur. This is called as all or none phenomenon. All or none law. What does that mean? If threshold is reached, definitely action potential will occur. If the threshold is not reached, no amount of time you give subthreshold stimuli, the action potential is not able to generate. All right. Under normal conditions, the action potential regenerates itself as it moves down to the axon. Hence, this property is called as propagation of action potential. So action potential is propagated. Action potential is all or none phenomenon. Action potential is mediated by depolarization followed by repolarization always. The action potential is the threshold stimulus is very, very important to bring about the action potential. So all these are the important points that we have learned today. With this, now let us try to understand what are the important properties of action potential. The first important property of action potential is to understand the refractory period. So refractory period. Refractory period is of two types. We have got absolute refractory period and relative refractory period. The absolute refractory period is a period during which no matter how strong the stimulus is, second action potential is not able to generate. This is called as absolute refractory period. I repeat, no matter how strong the stimulus is, second action potential never generates. This is called as absolute refractory period. It cannot induce a second action potential. The mechanism underlying this absolute refractory period is the fast sodium channels. It is because of the fast sodium channel activated state. Because of this, no matter how strong the stimulus is, the open activated or open inactivated state, both are responsible for the open activated or inactivated. The open type of the open mode of fast sodium channels is responsible for the absolute refractory period. The approximate duration of absolute refractory period depends on the length of the refractory period. All right. So the approximate duration is depending on the timing of this opening activated then opening inactivated conformational change. Please remember this point. Next is relative refractory period. Relative refractory period is a period which is stimulus which is greater than the threshold stimulus can induce second action potential. So what is relative refractory period? Usually there is no action potential in this area, in this point, but a stimulus which is stronger than the threshold stimulus, can definitely result in initiation of a second action potential. Say suppose we have got, this is -70, at -70, so suppose an action potential is generated, depolarization followed by repolarization. Got it? Depolarization followed by repolarization. So in this phase, as you can see, say suppose this is 0 and say suppose this is +30 millivolts of potential difference. So the area, the first half, so this part, I'll shade it in pink. So this part is actually the type of action potential which can in this give me a 5 minutes break for Azan. So welcome back. We were discussing absolute refractory period and relative refractory period. So in this diagram, the pink color shading which I did of action potential, this area of action potential, that is depolarization followed by repolarization till the reach of resting moment potential. In this, no matter how strong the stimulus is, second action potential is not generated. This is because of fast sodium channels, and you're calling it as absolute refractory period. Absolute refractory period. Whereas this area wherein a subthreshold stimulus cannot stimulate new action potential, but a stimulus stronger than the threshold stimulus can definitely stimulate and produce refractory period. You are calling it as relative refractory period. Relative refractory period. So these 2 points, please remember, right? We are discussing the properties of action potential. The first property which we discussed was refractory period. Next property we'll try to understand is conduction velocity. Conduction velocity of action potential. There are 2 primary factors influencing conduction velocity of the action potential. Conduction velocity of the action velocity. All right. Conduction velocity of action potential is determined by 2 things. One is the cell diameter. Another is the myelin sheath, the property of myelination. The property of myelination. Please remember, the cell diameter, the greater the cell diameter, the greater is the velocity. So the greater the cell diameter, greater is the velocity. The greater the cell diameter, the greater is the velocity. What does that mean? If you check the cross-sectional surface area, as the cross-sectional surface area reduces, the electrical resistance, hence the greater the cell diameter, greater is the velocity. So if you see thin nerve, a thin nerve has got more resistance, electrical resistance, than a thick nerve. All right. So greater the cell surface area, greater is the conduction velocity. This point, please remember it. Next is myelination. What do you think myelination is responsible for? Why is the nerve covered by a myelin sheath? Please remember that a myelin sheath provides a greater resistance across the cell membrane. It is to provide the greater resistance across the cell membrane. Thereby, there is no leaking of current from the nerve membrane. Please remember, this myelin sheath is not continuous. It is interrupted at some sites. All right. If you remember the neuron axon, say suppose this is the axon. We have got myelin sheath covered. No, this is the myelin sheath. This is the sheath covering. We are calling it as myelination or myelin sheath. So in between we have gaps. This is called as nodes of Ranvier. Nodes of Ranvier. And this is the myelin sheath. All right. In neuroanatomy, I'll teach you how is this myelin sheath formed, what are the derivatives of this myelin sheath. There are diseases wherein this myelin sheath is lost. We call it demyelination disorders, like multiple sclerosis, Guillain-Barré syndrome. In neuroanatomy, I will be teaching, and also in medicine, internal medicine, neurology also, I'll teach you this point. Please remember the diseases of the myelin sheath. So to understand this, we need to understand what is the normal function of the myelin sheath. So myelin sheath is interrupted at certain points. You are calling it as nodes of Ranvier, where in this nodes of Ranvier, the important point is here there is a cluster of sodium channels. So here lot of fast moving sodium channels are present. So these nodes of Ranvier are gaps of the myelin sheath. They have got fast sodium channels. So what will happen if fast sodium channels are there? What will happen to the action potential? Action potential appears to be higher, or the action potential actually hops from this point to this point, from this point to this point, like this. So saltatory conduction we call it. It is thanks to the conduction of fast sodium channels. So actually myelination with the gaps, thus it appears to increase the speed of conduction. So say suppose this myelin sheath is lost. Loss of this myelin sheath results in leakage of current across the membrane. All right. So if myelin sheath is absent, that the current will leak across the membrane. So what will happen to the threshold depolarization? What will happen to the depolarization? Always a subthreshold stimulus is formed, not a threshold stimulus. So no depolarization occurs. There is no conduction. We call it conduction block. So loss of myelin sheath results in conduction block. So if this is the axon, there is no myelin sheath. So previously, say suppose here myelin sheath was there. Because of demyelination, it is lost. So what will happen to the electrical stimulus or current? It is lost in the peripheries like this. If it is lost in the peripheries, it cannot conduct in this direction from one part of the neuron to the other, is it not? So that results in what is known as conduction block. So multiple sclerosis, it's a demyelinating disorder of the central nervous system, whereas Guillain-Barré syndrome is a demyelinating disorder of the peripheral nervous system. Usually affects the central nervous system, multiple sclerosis, whereas Guillain-Barré syndrome, it usually affects the peripheral nerves. Hence, in multiple sclerosis, patient will develop central symptoms related to brain or spinal cord, whereas Guillain-Barré syndrome, initially the symptoms arise from the limbs, peripheries. So peripheral sensation loss or motor weakness of the peripheries. All right, motor weakness of the peripheries and all. So that is the important point we need to remember in differentiating, and this is a disorder of myelin sheath. All right, so these are the two important properties of the action potential. One is conducting velocity and another is refractory period. Please remember, there is a test called as nerve conduction studies. In these patients, you do nerve conduction studies. In this study of nerve conduction, you apply electrodes on a limb and you provide small subthreshold stimuli to check whether conduction velocity is normal, is there any conduction block, to check whether action potential is occurring normally or not, to check whether refractory period is prolonged, delayed or absent or something like that. So this is how we check in a patient of demyelination disorder, and we come to a conclusion whether it is a motor disorder, ascending type of palsy, whether it is a patchy neuronal disease or it is a diffuse disease and all. We can easily differentiate. Next, we'll try to understand from one neuron to another, how is the conduction occurring. So if say suppose this is the neuron, it communicates with other neuron like this. All right. So in this direction, the nerve stimulus passes. So after this, what will happen? These dendrites will come and attach to the muscle. So say suppose this is the muscle belly. So the dendrites will come and they attach to the muscle belly like this. And at the site of attachment, we have got what is known as an important junction. We are calling it as a neuromuscular junction, NMJ, neuromuscular junction. So we'll try to understand the next important topic of synaptic transmission of action potential from one neuron to another, from one neuron to the muscle, neuromuscular junction. All right. So the synapse between the axons of a particular neuron and the skeletal muscle is called as neuromuscular junction. What is neuromuscular junction? I repeat, a synapse between axons of a particular neuron and a muscle. You are calling it as a neuromuscular junction. Neurons are of different types. Here we are talking about one important neuron called as alpha motor neuron. So this is an alpha motor neuron and this is a muscle. Junction between these two, you are calling it as a neuromuscular junction, alpha motor neurons and then a muscle. The terminals of this alpha motor neuron, if you expand this diagram to understand, we'll try to understand. So this is, say suppose this is the terminal portion of the axon of a neuromuscular of a alpha motor neuron. Here we have got vesicles filled with acetylcholine. These vesicles break. These vesicles get exocytosed. They come out like this, in this direction. So it is full of acetylcholine. Full of this acetylcholine. This acetylcholine has to interact with the acetylcholine receptors present on the neuromuscular junction. So suppose this is the muscle. This muscle has got certain receptors. We call it nicotinic receptors. These are the parasympathetic receptors on which the acetylcholine comes and sits. Once the acetylcholine comes and sits here, it initiates a sodium potassium activity, and this results in a ligand gated sodium channels, ligand gated potassium channels are present, which open up and which bring about the depolarization in a skeletal muscle. Thus there is contraction of that muscle. Muscle contraction occurs. Thus there is muscle contraction that is occurring. So let us try to understand what are the sequence of events. Action potential, which travels down the alpha motor neuron in this direction. The action potential travels down. This is the first step. From one nerve, another nerve gets stimulated. From there, another nerve gets stimulated. From there, this nerve is getting stimulated on your screen, and the action potential travels down the alpha motor neuron to depolarize the presynaptic membrane. So this is the presynaptic membrane. This is the first important step. After this, what happens? There is depolarization of this presynaptic membrane. Depolarization opens up voltage gated calcium channels, and because of this, resulting in influx of calcium channels. Calcium channel will enter into this area. There is influx of calcium channels in the presynaptic terminal. This is the second important step. Because of rise of calcium in the presynaptic terminal, the vesicles which contain acetylcholine, releases the content. That is, the acetylcholine is released into the synapse. It is the rise of the cytosolic calcium that result in release of acetylcholine. It's a very, very important point. The third point, rise of calcium inside the, so this rise of calcium here inside the presynaptic cell, presynaptic membrane, presynaptic cell axon, that results in release of the acetylcholine. So if some certain diseases wherein calcium is not able to enter and rise, the acetylcholine cannot get released and the excitation is stopped. Sometimes few muscle relaxants act like this by preventing the release of calcium and by preventing the release of acetylcholine. We'll discuss that in pharmacology. What happens when acetylcholine is released? It binds to the nicotinic receptor. It binds to the nicotinic receptor in the postsynaptic. So this is the nicotinic receptor in the postsynaptic nerve, in the postsynaptic skeletal muscle area in the synapse, wherein the nicotinic receptor is located on the muscle membrane. So this type of nicotinic receptor, you are calling it as NM. M stands for muscle. We have another type of nicotinic receptor called as NN, which is N stands for nerve. Alright, here NM type of nicotinic receptors, which is a non-selective type of receptor, and both sodium and potassium can traverse across this receptor. Ligand gated sodium channel, we can simply call it as sodium is much more has affinity to cause depolarization in this area. So depolarization of this area, we are calling it as end plate potential. End plate potential. Please remember, this neuromuscular junction is called as end plate. and when it gets depolarized, you are calling it as an end plate potential. The magnitude of end plate potential, how much is the end plate potential occurring? It depends on what? It is directly related to the amount of acetylcholine present in the synapse. So the magnitude of this potential is directly related to the acetylcholine present in the synapse. So what will happen because of this depolarization? Again, fast moving sodium channels open. The fast sodium channels open, and because of this rapid depolarization occurs in the muscle membrane. Because of this, what will happen is the depolarization reaches the maximum limit, and action of this acetylcholine has to be stopped now. So what stops the action of acetylcholine? There is an enzyme which degrades this acetylcholine. We call it acetylcholine esterase. Acetylcholine esterase enzyme. This acetylcholine esterase enzyme present in the postsynaptic membrane, it blocks the acetylcholine to act further. It will convert the acetylcholine to choline and acetate. So acetylcholine is getting converted to choline and acetate by this enzyme. Choline is taken back by the presynaptic terminal to synthesize new acetylcholine. We call it choline reuptake. Choline reuptake. Presynaptic terminal choline reuptake, we call this mechanism. Whereas acetate is, again going into some other biochemical reactions. So this is how the synaptic transmission occurs. All right. This is all about synaptic transmission between the nerve and a muscle. How does the synaptic transmission occur between neurons? Let us try to understand the synaptic transmission between the neurons. Let us try to understand the synaptic transmission in between the neurons. All right. So please remember that the synapse between the one axon, that is the dendrites of one axon, and the cell body, that is the cell bodies and dendrites. Actually, cell body and dendrites, they communicate with each other. Please remember that the synapse in between the two neurons is actually mediated by ligand gated calcium channel. Ligand gated calcium channels or sodium channels. All right. So the current that is produced from one aspect of the axon travels across this axon, reaches the dendrite, and from there it reaches the cell membrane of the next axon. The axon hillock, that is the initial segment of this region, it has got high density sodium channels, the fast moving sodium channels which initiate the action potential. High density fast sodium channels which initiate the action potential, and the closer the synapse, the greater is the transmission. So the intersynaptic distance, if it is short, greater is the transmission. And there is one important property of this synaptic transmission between neurons. You call it excitatory postsynaptic potential. Excitatory. We'll try to understand this property now. Excitatory postsynaptic potential, or in other words, you can call it EPSP. The excitatory postsynaptic potential is an excitability of the postsynaptic neuron. Excitability of postsynaptic neuron, which is more likely to fire an action potential from the presynaptic area. So this is a property of a postsynaptic neuron, and it is the amount of presynaptic firing that has occurred, presynaptic action potential which has reached. It determines the excitatory postsynaptic action potential. So primarily this is occurring because of increase in the fast sodium channels conductance. It is depending on the fast sodium channel conductance. We all know that fast sodium channel conductance is very, very high. So if sodium channel conductance is high, the EPSP or the excitatory postsynaptic potential is high. Please remember that there are certain receptors. There are certain receptors which are bringing about these changes. I already told you that the receptors present in the muscle and neuronal junction, neuromuscular junction, you are calling it as the nicotinic type of M type of receptors. Is it not? Nicotinic M type of receptors. In case of neurons, also we have got nicotinic receptors. So this is the postsynaptic terminal and this is the presynaptic terminal. Is it not? So here we have got the receptors, acetylcholine receptors here, the nicotinic receptors. What is the type here? Subtype? N subtype of nicotinic receptor. This is one type of receptor. Another type of receptor we have here. You call it NMDA type of receptors. NMDA type of receptor. It is an endogenous ligand. These are the ligand is excitatory amino acids. These excitatory amino acids will act on this non-selective channel to produce a response, a action potential of the postsynaptic neuron. We have got certain non-NMDA type of receptors also. So we have got three types of receptors in the postsynaptic potential. We have got nicotinic receptors, we have got NMDA and non-NMDA type of receptors, right? Similarly, similar to the EPSP, we also have got inhibitory postsynaptic potential, IPSP. So what is inhibitory post? The name itself is indicating that if the postsynaptic potential response is inhibitory, that is fall in the excitability of the postsynaptic neuron, any action potential which brings about inhibition of further action potential, you are calling it as inhibitory postsynaptic action potential. Inhibitory postsynaptic action potential, the important receptors are GABA and glycine. Please remember, there are only two types of neurotransmitters in the entire central nervous system which are inhibitory. So IPSP is because of inhibitory postsynaptic potential, that is GABA or glycine. Please remember, all other receptors, neurotransmitters, if you see, they are excitatory. All other neurotransmitters are excitatory. Inhibitory are only GABA and glycine. These two are having endogenous ligands, endogenous receptors, which bring about the inhibitory postsynaptic potential. You will have to remember this. GABA and glycine bring about inhibition. So if you want to stop the neuronal excitation, give GABA mimetic agents or glycine mimetic agents. Name a drug which increases the GABA channel activity. It is the benzodiazepine. If somebody is more excited and is not sleeping, you give benzodiazepine, sedatives and hypnotics, so that his GABA receptors are getting stimulated and increases chloride conduction and causes inhibition of the postsynaptic potential, causes inhibition of the action potential in the neuron, and patient sleeps. So this is what is the treatment that you give, pharmacological treatment that you give to cause inhibitory postsynaptic potential in epilepsy. In case of seizures, patient is throwing seizures, you want him to sleep, or a person is very much excited, he's depressed, or he's very much anxiety prone, you make his neurons to sleep for some time, and this is what is the GABA mimetic agents like benzodiazepines, alprazolam and all, and other different types of anti-epileptics will act. Now let us try to understand what are the peripheral nervous system made up of. The peripheral nervous system is made up of, the peripheral nervous system has got motor neurons, the peripheral nervous system has got parasympathetic neurons, parasympathetic fibers and sympathetic pathway. The motor neurons communicate with muscles with the help of alpha motor neuron, which releases acetylcholine, and which binds to the NM type of receptor. I already told you this point. NM type of receptor, and bring about fast action potential. We have got parasympathetic fibers. Here we have got preganglionic neurons. Preganglionic neurons release acetylcholine here. Ganglion is nothing but group of cell bodies, we call it ganglion. So preganglionic neurons, they release acetylcholine. This acetylcholine binds to the NN type of receptors to bring about an action. Postganglionic fibers also release acetylcholine, which bind to the muscarinic receptors. So postganglionic fibers, they also release acetylcholine, which bind to the muscarinic receptors, which bind to the muscarinic type of receptors. Muscarinic receptors are G protein coupled receptors, right? Then the sympathetic response. Sympathetic also we have got preganglionic and postganglionic. The preganglionic type of receptors in the sympathetic fiber system, they release acetylcholine, which binds to the NN type of receptor. Whereas postganglionic sympathetic fibers, they release norepinephrine. It's a very, very important point. Please remember this point. They release norepinephrine. This norepinephrine binds to either alpha receptors or beta receptors of the adrenergic system. The alpha receptors, alpha 1, alpha 2, or beta receptors, the beta 1 and beta 3 especially. The norepinephrine, postganglionic is norepinephrine, preganglionic acetylcholine. All parasympathetic pre or postganglionic release acetylcholine. One acts on nicotinic receptors, the other acts on muscarinic receptors. The sympathetic ganglion acts via if it is preganglionic, the sympathetic nervous system preganglionic acts via the acetylcholine, postganglionic acts via the norepinephrine. I'll draw certain diagrams to understand, to help you to understand this. Say suppose alpha motor neuron. Suppose this is the alpha motor neuron, and it acts via the neurotransmitter. Here is acetylcholine. It is acting on the skeletal muscle. It is stimulating the skeletal muscle. So this is alpha motor neuron. All right. If you talk about the parasympathetic, say suppose this is parasympathetic neuron. Parasympathetic neuron. So we have got, say suppose this is a preganglionic. Just 1 second. Some problem with the settings. Yes, I'm back. So I was discussing alpha motor neuron. I'm discussing alpha motor neuron. If this is, say suppose this is alpha motor neuron, it communicates with the help of acetylcholine, is a neurotransmitter, and it causes stimulation of the skeletal muscle. If we talk about the parasympathetic system, parasympathetic nerves, they act on the target tissue, target nerve, by acetylcholine receptors, which are nicotinic N type of acetylcholine receptors, if it is preganglionic. And if it is postganglionic, so this is preganglionic, postganglionic, this is the target organ, and this is the postganglionic. If it is postganglionic, it is via the acetylcholine again, but acting on the muscarinic type of receptors. Muscarinic type of receptors. All right. If we discuss the activity of a sympathetic system preganglionic, this is the sympathetic fiber, and this is the preganglionic sympathetic fiber. The preganglionic sympathetic fibers, they act via the acetylcholine receptors, which act on the nicotinic N type of receptor. Whereas the postganglionic action on the target organ it is via the norepinephrine. So postganglionic norepinephrine, preganglionic acetylcholine. This point you will have to make it, you will have to understand, right? Now let us try to understand few clinical scenarios which cause decrease in the nerve conduction. So decreased nerve conduction could result in weakness, muscle weakness. Decreased nerve conduction can bring about muscle weakness, or it may bring about paralysis. If you check the reflexes, deep tendon reflexes, hyporeflexia, or sometimes gait disturbance, ataxia, sometimes decreased sensory inputs resulting in sensory deficit, motor deficit. All right. If it is due to, it may, now this decreased nerve conduction may be because of many mechanisms. If it is due to ionic disturbance, say suppose ion channels are involved, for example hypokalemia, for example hyperkalemia, hypokalemia, they decrease the nerve conduction. All right. Or chronic hyperkalemia. I told you how does chronic hyperkalemia act? By decreasing by prolonged inactivated state of fast channels, is it not? Fast sodium channels. So hyperkalemia, chronic hyperkalemia, or hypokalemia, or hypercalcemia. This is one important point. Loss of myelin, demyelination, can be one method of one type of disease, demyelination, resulting in decreased nerve conduction. I already discussed this point. Demyelination is one important problem with the conduction, nerve conduction. All right. Next, certain problem at the neuromuscular junction. Like for example, patient is using certain drugs. We call it neuromuscular blockers. Neuromuscular blockers drugs. It can be depolarizing blockers and non-depolarizing type of blockers. I'll discuss this in pharmacology again. Depolarizing blockers and non-depolarizing type of blockers. Just one second. Depolarizing type of blockers and non-depolarizing type of blockers. Or sometimes certain toxins or drugs. All right. Certain disorders like neuromuscular junction disorders like myasthenia gravis, or Lambert-Eaton myasthenia syndrome, or botulinum toxin. All these are agents which act on the neuromuscular junction and cause decreased nerve conduction. Similarly, let us try to understand what are the conditions involved in increased neuronal excitability or increased nerve conduction. Increased nerve conduction. Ion disturbances like, you have guessed it right, either hyperkalemia or hypocalcemia. Hyperkalemia or hypocalcemia. Increased nerve conduction can be seen in few conditions of myelin disorder like multiple sclerosis. Multiple sclerosis. Certain drugs like acetylcholinesterase inhibitors of acetylcholinesterase, all right, sometimes because of chemotherapy. Increased neuronal excitation is an important point of chemotherapy, few chemotherapy agents. So all these disorders will increase the nerve conduction, whereas disorders which decrease the nerve conduction I already discussed. So this completes the topic of today's discussion. Hope you have followed it. If you have any doubts, please communicate with me and I'll be happy to help you out. Thank you very much.